Hey everyone, and welcome to this explainer. Okay, so did you know that a disease we usually associate with adults can actually be way more aggressive when it strikes during childhood? Well, today we're taking a clinical journey right into pediatric inflammatory bowel disease, or IBD. We're going to explore the whole shebang, from its tiny microscopic origins all the way to practical, on-the-ground bedside care. We'll see exactly why this condition demands such incredibly specialized, vigilant attention when it comes to our younger patients. Let's get into it.
All right, first things first. Let's dive into this and clear up a major misconception right off the bat. IBD is not IBS. I know, they sound super similar, but they are completely different beasts. Irritable bowel syndrome, IBS, is a functional disorder. It causes abdominal pain, changes in bowel habits, things like that. But IBD, inflammatory bowel disease, is actual, physical, chronic inflammation of the intestines. We're specifically talking about major, serious conditions here, namely Crohn's disease and ulcerative colitis.
To really wrap our heads around the impact of this, think about this number. Right now, there are about 70,000 children in the United States living with inflammatory bowel disease. 70,000. And like I mentioned, both Crohn's and ulcerative colitis tend to be far more aggressive if they start in childhood. We are definitely not just talking about your average occasional stomachache here. These kids face a lifelong, chronic condition. It's marked by really severe exacerbations and then periods of remission, often without ever completely getting rid of their symptoms.
So, to guide our journey today, we've got a clear roadmap. First up, we'll cover the basics of IBD. Second, we'll compare the pathophysiology of UC and Crohn's. Third, we'll look at signs and symptoms. Fourth, diagnosing the disease. Fifth, treatment strategies. And finally, we'll wrap up with complications and clinical care.
Okay, Section 1, the basics of IBD. Let's start uncovering where this actually comes from.
So, despite decades of intense research, there's still no known cure for IBD. But we do know its origins point to a sort of multifactorial perfect storm. Basically, it's a massive collision of genetics, your environment, and microbes, all coming together to cause defective immunoregulation in the GI tract. Think of it like a giant puzzle. For one, genetics. Genome-wide studies have confirmed over 150 different genes that bump up a person's risk. But the environment is a huge piece of the puzzle too. For instance, when children immigrate from developing nations to Western countries, their incidence of IBD actually shoots up to match Western populations. Crazy, right? And finally, microbes. A healthy intestine is home to about 10 trillion bacteria and fungi. But kids with IBD, they show a remarkably small diversity of those intestinal bacterial species.
Moving right along to Section 2, ulcerative colitis versus Crohn's pathophysiology. It's time for a true tale of two diseases.
Now, while ulcerative colitis and Crohn's disease share a lot of immunologic features, the actual structural damage they cause is vastly different, and this brilliantly illustrates the contrast. With ulcerative colitis, or UC, the inflammation is strictly limited to the colon and the rectum. It affects continuous, unbroken segments along the bowel, and it stays relatively superficial, meaning it's only really damaging the mucosa and submucosa layers. Crohn's disease, on the other hand, is a whole different story. It's chronic inflammation that can strike literally anywhere from the mouth all the way down to the anus. And unlike UC, Crohn's is transmural. That means it penetrates deeply through all layers of the bowel wall. Plus, it happens in what we call skip lesions. This means you'll see diseased, inflamed tissue sitting right next to perfectly healthy tissue, skipping around the GI tract.
All right, Section 3, clinical signs and symptoms. Let's look at what the child is actually experiencing day to day.
Now, what's really interesting about this is that because the microscopic inflammation behaves so differently in these two diseases, the daily, real-world reality for the child diverges pretty significantly too. Take ulcerative colitis. Because it causes continuous ulceration in the highly vascular colon, rectal bleeding becomes a really common hallmark. Conversely, since Crohn's deeply affects the entire GI tract, we see much more severe systemic issues. We're talking things like anorexia, profound weight loss, and even growth retardation because their bodies just can't absorb nutrients properly. Furthermore, because those Crohn's lesions pierce through all the bowel layers, anal and perianal lesions, strictures, and fistulas, which, by the way, are abnormal tracts connecting the intestine to other organs, those are super common. Whereas in UC, those severe structural complications are actually quite rare.
Which brings us to Section 4, diagnosing the disease. Time for some careful medical detective work.
So how do we actually tell these two apart? Well, distinguishing between UC and Crohn's requires a really multi-pronged approach. It starts with a super thorough history and physical exam. You really have to pay close attention to things like growth failure and delayed sexual maturation, Why? Because those issues can actually present for years before any obvious GI symptoms even show up in Crohn's. Next, clinicians will run specific laboratory tests. A CBC to check for anemia from blood loss, and an ESR or CRP test to measure the systemic inflammatory response. Finally, imaging and endoscopy. A colonoscopy allows for direct visualization and biopsies of the tissue. This is where you actually see those diffuse abnormalities and micro-ulcers if it's UC, or those discrete deep ulcers and skip lesions if it's Crohn's.
Okay, Section 5, Medical and Surgical Treatment Options. Let's talk about how we fight back.
Once we have a diagnosis, the big question is, how do we induce and maintain remission? Well, treatment is incredibly individualized. For mild to moderate ulcerative colitis, medical therapy often relies on 5 ASAs, like mesalamine, to help decrease that surface inflammation. But for Crohn's disease, nutrition itself is actually highly therapeutic. An elemental diet, which uses special formulas that are completely absorbed in the small intestine, can literally serve as a primary therapy to induce remission. When it comes to surgery, the two diseases differ wildly. Because UC is entirely confined to the colon, a total colectomy can actually cure the disease. But for Crohn's, it's a delicate balance. Surgeons might perform segmental resections to remove strictures, but because of the nature of the disease, once you reconnect the bowel, the inflammation often just recurs.
Finally, Section 6, Complications and Clinical Care. Let's bring this down to practical bedside reality. You know, managing IBD goes way, way beyond just treating acute flare-ups. It's a lifelong companion that requires constant vigilant care. And one of the most sobering long-term complications we have to watch for is the elevated risk of colorectal cancer. This isn't just a quick fix, it's a lifetime commitment to surveillance. Because the risk for colorectal cancer significantly jumps up about 8 to 10 years after an IBD diagnosis, clinical guidelines are super strict here. Regular surveillance colonoscopies, complete with multiple biopsies, absolutely must begin about 7 to 10 years post-diagnosis, and that goes for both UC and Crohn's patients.
Now, during those acute exacerbations, managing hydration becomes a totally high-stakes balancing act. So the crucial point is this. When a pediatric patient is experiencing severe diarrhea and vomiting, hospitalization for IV fluids is frequently required. And we really have to look closely at their blood test results, specifically for proteins like albumin. In our bodies, albumin acts almost like a sponge inside the blood vessels. It helps keep water in the vascular space. If albumin drops too low, that fluid just leaks out, leading to tissue edema. Clinicians have to monitor these fluid shifts incredibly carefully. If a shift is administered too rapidly, water intoxication becomes a highly, highly dangerous possibility.
So, bringing it all together for the nursing students and caregivers providing that crucial on-the-ground care, these are your absolute vitals. Beyond managing those delicate IV fluid shifts and monitoring albumin, skin protection is absolutely paramount. Because children with Crohn's are so prone to perianal lesions and fistulas, it is vital to keep the perianal area meticulously clean, leave it open to air when appropriate, and diligently apply barrier creams to prevent severe skin breakdown. And then there's nutrition. Caregivers have to combat the massive caloric burn of inflammation and nutrient loss. We do this with a high-protein, high-calorie diet. But the trick is breaking it down into small, frequent meals to encourage a child who might be feeling anorexic or nauseous to actually eat.
When you strip away all the complex genetic markers, the fluid management protocols, and the surgical threats, pediatric care fundamentally boils down to one simple unifying goal. We want to achieve remission without pain or bleeding. Ultimately, we are striving for an optimum quality of life that lets these kids just be kids, minimizing any impairment to their daily activities. That is the true quality patient outcome we're after.
I want to end this explainer by challenging you with this thought. We've seen exactly how physically demanding IBD is, but take a second to think about the incredible emotional toll this takes on a growing child. So what does this all mean for us? How can we, as a community of learners, clinicians, and caregivers, build a long-term, multidisciplinary safety net, one that doesn't just treat an inflamed bowel with medication and barrier creams, but truly empowers that child to look past their chronic diagnosis, navigate the messy challenges of adolescence, and reach their absolute full potential? Keep that question in the back of your mind as you continue your studies. Thank you so much for joining me today, and keep learning.